positions? Yes? You're okay with those dates? Okay, yes, 2. All right, any add-ons?
We do not have any add-ons.
Anything else to comment about?
No.
Okay, all right, so we'll go right into Smarten.
No,
Oh, I'm sorry, am I wrong?
and I think we have one other thing prior.
1 o'clock,
Yeah.
oh,
Shannon.
Shannon
That's
Martin.
smart, that's what he says.
Yeah.
Ricker Graydon.
Yeah.
Oh, okay, so Shannon
assume
Martin's
that's
not here
you.
today.
I was gonna say,
Okay,
it's not Shannon Martin, but you're a bigger.
you're the fill-in.
All right,
I'm Julia Knesny from Brooker Graydon. I'm actually in our Columbus office. Shannon's down here, but I'm just coming on behalf of bond counsel to Otterbein Homes for this issuance of not to exceed $50 million for senior independent living. This is very similar to the deal we did last year, right around this same time. Same thing where we had the public hearing, we went to all the other counties, got their approval, and then we come to you to issue bonds. Happy to answer any questions, but it's pretty much the same thing as last year. Same structure, same conduit kind of thing. The county's not, this is not the county's debt. There's nothing to worry about here.
okay, any other questions?
I would say resolution.
I do have a resolution, determining the necessity of and authorizing the issuance and sale of not to exceed $50 million of healthcare facilities improvement revenue bonds, Series 2025, Otterbein Homes Obligated Group, authorizing the execution and delivery of agreements of lease and subleases in connection therewith, authorizing the execution and delivery of an indenture of trust, bond indenture, to secure such Series 2025 bonds, authorizing the execution of a bond purchase agreement with respect to said Series 2025 bonds, and authorizing a tax certificate and agreement and various other documents in connection with the issuance of the Series 2025 bonds.
So moved.
Second. All right, call the roll.
Mr. Grossman?
Yes.
Mr. Young? Mrs. Jones?
Yes.
Okay, thank you so much.
Thank you.
Great. Safe travels back to Columbus.
All right, so, is there anything else for this portion?
No,
of this
there's
meeting?
someone here, I don't know if they want to address.
Okay, does anybody want to speak before we close this meeting? Okay, then,
She did.
did you, okay, please come back. Yes, you do. I'm sorry, we can't, we need to have you, anything that's said in public, we have to have you on our monitor, which records video and,
Okay, hi, my name is Claudia Humphreys. I'd written a couple letters,
Claudia, could you give us your address, please?
2142 Tumbleweed Lane, Lebanon, Ohio.
Thank you.
And one of the letters, I proposed something that Warren County matches the credit that the state gives us for the homestead exemption. It would be a nice gesture as far as, you know better than I do how much the taxes, property taxes have went up. And I'm paying right now, I think it's between $3,500 and $4,000 a year. That is so much that has to be put aside each month, and I'm on a fixed income. So it makes it kind of rough. So I just wondered if you guys had considered that seriously, if it's going to be able to be done.
So we actually are in the process, we have instructed our staff in the prosecutor's office to look into the matter. We had a conversation maybe 2 weeks ago in public session about this. So we're certainly considering it and finding out what our options are. So I appreciate your feedback.
Well, and another thing too, I know, or this is the way I've been told, the state mandates that the county stay within a certain market value of the homes. Well, we all know inflation and everything else. My home is not worth what I'm paying insurance on, because they come in, because I have replacement value on it, and I'm going, whoa, In the last 2 years, my insurance, of course, this is a separate issue, but it all works together about the inflation. My insurance has went up. I have had no claims between $300 and $400. I mean, this is, it's rough.
Are you questioning the appraisal of the market value of your property? by
No,
the
not
auditor?
with the way the market is right now. But I don't know, it seems like there should be some kind of, credit or something that if it continues to go up, you know, if I live that long, if it goes up the way it is now, my house is going to be worth $1 million in 10 years or 5 years or whatever, and I'm not gonna be able to pay the taxes on it.
Yeah.
Well,
So-
we all know that the property taxes are difficult on people, particularly such as yourself.
Yeah.
We are having it looked into with regard to this homestead exemption,
Mm-hmm.
and we've asked for further information about the impact of that upon those entities within our county that rely, particularly the schools, on taxes,
Mm-hmm.
on property taxes. And of course, you know, our auditor's been very active testifying and advocating for a solution to the kind of problem that you're facing with very large property taxes, particularly on fixed income people and the raising of those. But it's a complex issue because of the fact that half of the county's income comes from real estate taxes. All of the townships come from real estate taxes. The schools are heavily reliant on real estate taxes. But there are ideas to solve this problem that I know are being looked at. And we are also looking at the homestead exemption, and we're gonna be getting to that within, I think it's before the end of the year, we will be making some decisions on that.
Well, I appreciate that, and I just want to say too, everyone that I have spoken to in Warren County, and that I have spoken to the staff of the 2 representatives, the state representatives, and Steve Wilson's staff, Jacob. He probably says, I hope that woman doesn't call me anymore. But, you know, they've all been very nice, very helpful, and I really appreciate that.
Well, that's nice to hear.
Yeah.
I would, just also say, I agree with you on the valuation piece. And that's something that the state legislature, I hope they look into, and how
Yeah.
they can limit the valuation for taxation purposes, because I think that's something they could and should consider and do. So I agree with you on that. I really do appreciate you being here today. And
I
sharing.
appreciate you guys letting me come up and speak, and like I said, everyone that I've dealt with has been more than helpful, and they've told me the truth, which that's very important. And like I said, Jacob with Steve Wilson's office, he says, don't call me no more.
I
He's been
doubt
very-
that. I
He's
doubt
very
that.
nice, very nice. So thank all of you for
Thank you so
listening.
much. Have a good day.
You too.
All right, is there anyone else?
I make a motion to adjourn our general session.
Second,
And yes.
it's rare that we haven't had an executive session. So now we
Okay,
can-
now we're gonna open up our work session agenda. And can we go into our work session agenda before it's scheduled at 9:30? I
Yeah.
assume we can. So, who's gonna speak on behalf of our benefits issue? Who wants to talk first?
I'll introduce our hub team.
Yeah, you
So
jumped
there-
up here before, so you were ready.
Ready to go. So we have Allison and Steve from Hub. We're here to talk about the 2025 plan that we're in and projections for next year for 2026. So Allison.
Sounds good. Thank you, Tammy. Good morning, everyone. Great to see you. Thanks for having us. Once again, I'm Allison Ruhlman, benefit consultant at Hub, formerly Horan. So looking forward to talking through 2026 renewal recommendations, kind of where we are from a budget perspective, and recommendations going into 2026. All right, so just briefly on the agenda here, we'll go through historical analysis, just kind of how we've been running year over year, and then get into 2026. So what we anticipate from a budget perspective, and then some of the recommendations we have, cost containment strategies, some of which you already have rolled out, but we recommend to continue as we go into 2026. And then we'll get into the ancillary or the other benefits outside of health insurance. All right, I'm gonna go quickly through this because these slides you've seen in the past. We just like to add another year of data to just show you historical analysis, how the county has ran compared to trend.
So looking at this overall trend that we're seeing in the marketplace is around an 8% year over year. Warren County, if you look at this, I know that we've had some ups and downs, but overall.
When you say plan cost, health, what plan?
Health insurance. So plan costs, but we talk about claims.
So
and
just
fixed
health right
costs. Correct. Self-funded plans.
Plans or plan, is it the health insurance or everything?
So health insurance. So the
Okay.
self-funded health insurance.
Okay.
Yep. So when you look at your claims cost and then the fixed cost that you pay. So 7% is typically the trend we're seeing. Over year, we're seeing the county to be 2.3 when we look at the cumulative 10-year cost trends. So good news there. I know that we've had some ups and downs, but like I said, when we think about the long-term stability, it certainly is there. All right, I know there's a lot of words on this slide, so I'm just gonna breeze through it. I think the main thing I wanted to focus on is looking at your annual goals and priorities, meeting with your benefits team, Martin, Susan, understanding what those goals and priorities are in 2025. I think your team has done a great job of achieving those. Looking at different cost containment strategies to understand what we're doing from large claimant risk, pharmacy spend that we'll go into, and then overall just the other great value adds that you offer to your employees. You had a great benefit fair earlier a couple weeks ago, just talking through the value adds, the benefits, educating your members on all of the great benefits that the county offers. I won't go into all of this because we have a lot of information to share today, but 2026 is really, we're going to focus on some of these cost containment strategies that we have implemented in 2025, moving forward, making sure that we're continuing that long-term stability. All right, so we'll get into 2026. The first thing here, and I might lean on Tammy here a little bit on the overall proposed budget from the county. So working with Tammy and her team, the suggested increase is coming in at a 2.5%. I know that we've been standing up here in years past and that number's looked a little bit larger, so happy to say that due to some of those strategies that you have been implementing, we can come up here and say that we do believe that 2026 should be more of a stabilized year due to those strategies. The budget does include more than just the health insurance costs, right? So this all-in budget includes all the administration fees you pay, all of your benefits. So when you think about, you know, Sun Life, United Healthcare, for your HRA, FSA, all of those things incorporated in that, as well as stop loss premium, claims, and then like we mentioned before too, some of those other value adds that you offer when we think about, you know, things like Weight Watchers or the Tri-Health EAP, those things are all embedded in that all-in budget. Any questions on that? All right, well, let's get into these recommendations. The first one we wanted to focus on is pharmacy. I know pharmacy is a topic of conversation that we bring up pretty frequently just because it is a higher than medical trend that we're seeing in the marketplace, and we really want to do our due diligence of maintaining those costs. So as you are aware, in 2025, we implemented a new pharmacy benefit manager, PBM, working with ArrowRx and Evo as your pharmacy partner. The goal here was to, it says remove high-cost drugs from the county plan, but making sure that the member experience and how the members are getting the coverage is still low cost, and they have access to those medications. So we do that by leveraging manufacturer assistance directly from the manufacturer. So, you know, when you think about specialty medications and being able to get that directly from the manufacturer, that comes off of the county's budget and all-in cost. Another big thing that we've heard in 2025 with this change is just the white glove experience that your members are receiving. They no longer have to call a 1-800 number on the back of their ID card. They talk to direct people familiar with the county's pharmacy plan and just ensuring that they're getting the service and that concierge experience to the best of their ability. Projected year one savings
When we came up here last year, we talked about those savings to be anywhere from $1.6 to $1.9 million. I'm happy to say that we are on target to receive the savings. Now, what I will say here is this is total gross savings, so we net out any rebates that we receive from OptumRx or Evo. All right, so this is truly all-in gross claims savings. Lots of numbers on this chart, and so I won't go into detail here. The big thing is to see on the far right-hand side of that savings column, just to see month over month, the savings the county is receiving by leveraging those manufacturer assistance or leveraging the international sourcing of brand drugs to take those off of the county plan, while still making sure that your members are getting those medications and typically at a lower cost. A few wins on the right-hand side. A lot of this focus is on those specialty and brand medications. So have a few different examples here of what the Optum Rx annualized cost of medications are compared what those annualized costs will be with Evo in 2025.
Is that our cost?
Correct. Total all-in cost. Another big win too, I don't have to go in all of the details here, but year or month over month, we look at your high-cost claimants, and just, you know, those are the ones that are typically driving the cost of the plan. When we look at that for 2025, there are no RX pharmacy large claimants in your top 10 report. Standing up here last year, that was a different story. So good win there. And like I said, the member experience, there's some other great examples of just not necessarily even the high cost ones, but just understanding your membership, making sure that they're getting the medications they need, and working with them and their physicians to achieve those goals.
I mean, I see Ozempic on here. There's a couple of questions that come to mind. Number one, does our plan pay for it if they're all obviously prescribed? Does it meet certain, you know, where does it come in that it's a necessity drug versus a choice drug would be? Is there a difference?
Yeah, that's a good question. So a few years ago, the county implemented an expanded preventive drug list, essentially through Optum. It's more expansive than your typical preventive drug list that, you know, the typical ones cover like the metformin or some of the lower cost generics. With this expanded preventive drug list, still FDA approved, so the member can get it at no cost. But the goal of that was to increase adherence and just ensuring that, you know, if members have access to these medications for free, then they're more likely to continue to take them because a lot of them are maintenance medications. Some of these drugs like Ozempic, a few of the other GLP-1s, they did get added to this expanded preventive drug list. So we did see the cost the county was paying for these medications go up, mainly because more people were taking them, right? When we did talk about this last year, it came up as ultimately a good thing in a way, that we want to make sure people are taking the medications that they should be taking to hopefully prevent, you know, a catastrophic thing in the future. So yes, it is FDA approved to be covered at no cost for your members.
Okay, so basically any prescription, any doctor writes you a prescription for it, and you're on the plan, it's covered by the plan.
It still requires prior authorization.
Correct.
So you have to meet certain conditions in order to be eligible for that. So it's not anyone.
Correct.
It's not, it is prior authorized.
Okay.
So we have, you know, there's a lot of interesting recent research about these types of drugs, which I find fascinating, but also that indicate that perhaps everybody should be on a low dosage of these drugs, because they're controlling how you process sugar in your body. And there's a lot of damage that is done to you with sugar, and this is why these originally were diabetes drugs. But then they discovered that it had this other really wonderful benefit, particularly to people that felt like they were too heavy, and that they could lose weight with this. And we know that excess weight is a big health risk and health factor. So I wonder why we couldn't look at allowing people to be on this drug because we want people to be well, we want them to be healthy, we want them to be, you know, I was suggesting that we look into giving people memberships or helping them with memberships to athletic facilities or something like the Y. I'm wondering why we couldn't, because these drugs are now being so widely used, including perhaps not through normal prescription services, but because they have now such a wide recognized benefit to health in general, to recategorizing these. I mean, I manage to deal with this without having this problem, but I know a lot of people have found this to be very, very helpful to their health in general.
Yeah, yes, I think that's all good points. The world of the GLP-1s and understanding the long-term philosophy, if you will, of how to cover, how to manage the cost of these. I think that they're all valid points, and I think that we're at a place of just trying to understand. It's still so immature that we're looking for more of that long-term data to see, to some of your points of where this is going to go. Currently, the county does cover weight loss medications. When we think about just overall our book of business, I would say it's more on the lower end of clients that cover weight loss medications. However, when we look at county governments on a national level, 42% do cover weight loss medications. So it's certainly something that we see more in the public sector than we do in the private sector.
Do we cover weight loss medications?
You do, correct.
But only if you meet certain criteria?
Correct, yes. So there are still prior authorizations in
What criteria
place.
is that?
Depending on like BMI level, for example, that's one of the main criteria for covering. There are ways.
You just said something I don't
It's more
understand.
restricted.
Sorry, body mass index.
Okay.
So yeah,
Thank
yeah.
you.
So depending
I
on
thought you said EMIs.
no, sorry, BMI. Yes.
Okay.
There are other ways and avenues. You know, being self-funded, you have the opportunity to manage that however you wish. You know, if somebody needs to meet with a health coach or things like that, there's other options.
Well, let me go back to when you said body mass index. So you have to have some specific body mass index, like you have to be considered obese or something like that to get on this drug?
I don't know what
Yes.
the actual
I can speak
threshold.
from experience, both for using one of these drugs, not the one listed here, but in the prior authorization process. It is very restrictive. You have, in fact, I suspect everybody who is on this drug through the plan has probably been denied it, even though they make those qualifications, because that's what the insurance companies do. And it's a pretty big process to get this approved through our
You see,
plan.
when I was going in kind of a different direction with my question, because I get that there's that thing going on, but it's my understanding that once you get on these drugs, maybe I'm wrong about this, because I don't understand completely how this drug works, except what I've read is that once you're on it, you have to stay on it, or at some level have to stay on it, even though you've maybe reduced, so that at the point you're at, when you get to some terminal, like, okay, I'm exactly where I want to be, but if you go off it, you'll start to gain weight again. And then you'll yo-yo, which is, you don't want that to happen. So how does that work with our plan?
Yeah, so there's no like barriers of how long you have to stay on it or you have to come off of it.
No, I'm
It's
saying, once
nothing-
you reduce yourself so that you no longer would fit the initial criteria, do they
Yes.
remove you?
No, you stay, well, you have to, there's a prior authorization every 12 months, for a lot
Oh,
of
so
these
they
brand
check to
drugs.
see if you meet the same criteria every 12 months?
Yes,
Yes.
so it's
So
a,
if you, if
And
it's
when you say
successful-
they, you're actually saying us, because we are the plan.
Well, that's what I mean, but I mean,
the
then all of a
pharmacy
sudden,
benefit manager.
but then all of a
You know,
sudden, if you have this 12-month thing, and in the 12-month period, I don't know how long it takes to get this stuff to
So,
work.
and that's actually why I asked the question initially, was this, basically for specific obese folks, or, other people would say, oh, is it for cosmetic?
Yeah.
That, hey, I'm choosing to do this. So there is a criteria that right now that you have to do this. So then it goes to, is there enough data to say, is our current structure good, or is that too restrictive?
Right.
Should because when we say they, it is us. We are the plan. So we tell the insurance company how we want to cover these things.
Yep,
Correct?
exactly. Yep.
Okay,
Yep.
so I want to be clear about that. When
Yeah.
we say they, it's us. So that's our restriction right now, is that we have something for basically obese people. That if you meet these certain criteria of the definition of obesity, you can be on this drug. And then, that's interesting when you say you have to requalify. I guess that means.
And
that even-
actually, that would only apply to a drug where there are no other conditions. So, for example, Ozempic, BMI is not the only qualification. You have to have, metabolic disease, meaning you have to have also diabetes, high blood pressure, high cholesterol in order. So it's even more restrictive with what those sort of diabetes treatment like Ozempic.
Okay.
So
fair enough.
there's only, the FDA has only approved one drug for weight loss for severe obesity, for which that would be the only qualification. And even in that, there is difficulty in getting that approved, even if you meet that.
Okay, fair enough. So it's kind of setting the table, how do we stand today? And then what you're saying is also, Commissioner Grossman's point about long-term studies have not shown exactly what this looks like long-term, because it hasn't been around for a long term.
Correct.
So we don't know exactly. We know what the short-term benefits are, and they're tremendous, because
Yeah.
people's BMI have come down, healthier living, all that type of stuff, which then goes into my other, where I was going with the initial question, was the correlation, because you know me in insurance, I love planning ahead and doing everything that we possibly can.
Yeah.
Number one, for the benefit of our employees. Number two, to save us money. I'm about saving us money.
Yeah.
And sometimes it's, oh, well, you're spending this money. Sometimes when we've spent money, we've saved money because we're 100% heading things off at the pass.
Yeah.
So now, when you come in and talk to me about a 2.5% increase, what is our utilization for these GPL ones? And is there any type of a direct correlation that we could say is as a result of some of our highest risk folks that are on the plan are now on this, some call it a miracle drug, that all of a sudden they're healthier? Has there been a correlation with reduced cost of our plan, or is it too early to tell? That's exactly where I was going.
Yes, that's a great question. And to answer that, yes, I believe it is too early to tell. It's similar to the approach of offering that expanded preventive drug list, right? Of making sure people take these to hopefully help long-term medical spend, right? Reduced inpatient spend, outpatient spend, those type of things, emergency room, etc. So yes, I think you're right on track with that, and that is something that we are tracking for the county in particular, but also our book of business to see, people covering these specifically for weight loss or specifically just for diabetes management, how that impacts long term.
So, and again, from what I've heard from my colleagues, that there's almost there's really four things we could do. Number one being, we're not covering it, period. No matter what, we're not doing that. So one option is keep doing what we're doing, which is, it's tough to get. You gotta jump through a bunch of hoops. You gotta continually jump through hoops. And it's not just based on BMI, there's other criteria involved. So fairly restrictive. Is that a safe statement?
I think the shortage, supply, and demand is something that pops up with that
but
too.
that's-
It's fairly restrictive. I mean, I can speak over 2 years of experience. It's fairly restrictive, and and there were shortages of the drug. 2 years ago. It feels like the supply chain is that.
It has. That's why they've reduced the compounding ones.
That's right.
That it's the name brands have ramped up production. The supply and demand has become, because supply has gone up.
Well, and there's some that are coming out too with the oral pill
Correct.
version.
Do they have generic brands of this too?
No, not today.
Yeah, because they're all still patented.
Yeah.
Because everybody spent tons of money on
Yes,
these, and they
yes.
just became
Well,
name
I
brand.
guess my question about that is not a generic brand of exactly what you know, Ozempic or Wegovy or all the other ones that are in this category, but whether there are ones that are being processed that are not exactly like them, but do serve the same function. I just don't know. And I recently got an email from Costco that they're gonna now have these things at half off
Yeah.
of these name brand GLP-1s. And I don't know whether, you know, obviously I'd rather everybody get it half off at Costco than, you know,
Well,
go.
I can say that one of the things that, they've done with the plan, or we've done with the plan this year, is sourcing the drug outside of the United States in Canada, where it is, you know.
Tremendously less.
Tremendously less.
Right.
And so I think all of those things from a cost containment, just because I've been really involved in this conversation with them, because I've been, you know, it's been something I've been impacted by, but also I think the question you raised, Tom, about the microdosing, that there's all this research on, I mean, I think this is gonna be not necessarily something for today, because to Allison's point, it's still, you know, in the investigative stage, but I think there's going to be, you know, more that we're gonna learn about this as time goes on. I mean, these drugs have been around for a long time, but just specifically with the diabetes management.
That's correct.
And so, and you know, it's like, yes, I think physicians are still trying to figure out, and it's probably different for everybody, once you've reached your goal weight, like what does then ongoing maintenance look like? And that's, people are sort of experimenting with
Yes.
that, and
Yes.
you know, so nobody wants to be on it forever, and so, you know, we're still trying to figure all of that out. And so I'm just, you know, I'm just one schmo, just speaking from experience to say, you know, this has been life-changing for me, and while it's anecdotal and not reflective in your numbers necessarily, that is too soon to tell, I can say with 100% certainty that, you know, the costs with respect to my healthcare are down. So,
Well, having said all that, I don't know how we do this, but I favor us being less restrictive.
Yeah. Yeah.
Which is option number 3. So one option, we don't allow it on the plan. 2, we're fairly restrictive. 3, let's talk about, and 4, Commissioner Grossman brought up, let's just have everybody kind of do a microdose of it, you know, which, so that's almost the 4 ways of doing it. And with 3, it would be, can we make it marginally less restrictive? Yeah, we don't want it, and that comes into a philosophical question of, do we want people on it for cosmetic reasons? Do we want people on it to lose 5 pounds or 8 pounds just because they want to look better or what have you?
Yeah.
Versus, is it really a health condition? And then should we, the taxpayers, be paying for that if it's clearly just kind of a, but it's not, I can't even say it's clearly a cosmetic thing now, because there might actually be
Right.
ancillary health effects
Yeah.
of that. So that's, and then
Yeah.
that's where it gets into maybe too early to tell.
Yes. I think that all of these are great points, and I have a feeling next year when I come, we'll have more mature data on where things sit with this and our recommendation for how to cover those going forward. To your point about making them less restrictive, our only concern or evaluation as we continue are these drugs continue to more and more get FDA approved by the month, right? And so as more of these get approved, the cost of those are obviously going to go up. You know, per script costs for these range anywhere from $1,000 to $2,000 a month. And so when more of these become available, obviously the uptick might occur. So understanding, you know, the prior authorization process, we do want to make it less cumbersome, but how to make sure that we're managing the plan appropriately. And to the dosage question, you know, Commissioner Jones brought up the international sourcing, which definitely has saved the county a good chunk of change, a lot of these being those GLP-1s. What we're seeing in Canada, the dosage requirements are different than what they are in the States. So for example, Zepbounds, you only can get a certain amount of dosage in Canada compared to what you can get here in the States. Same thing for some of those other medications. So when we think about international sourcing, when we think about microdosing, those are the conversations we love to have of what we do going forward once we have more of that mature data and more of those medications being FDA approved. I don't know if that's helpful.
Okay, I don't know where we're at, but,
Well, no, I mean, I think.
It's still very new.
Well, the only thing I'm thinking about is, do we even now say, do we tweak it a little bit to make it a little bit less cumbersome? Do we, or is this a good thing? Do we want to encourage our employees to utilize this more if they're still the highest risk users to the plan?
I think it's up to the doctors and the patient to determine what the best course of action is. I have no problem with that, and I certainly have no problem with prior authorization. That's a standard, that's standard for lots of drugs. What I think I would want to make sure is that when we talk about the word they and that it's us, it isn't us that's automatically denying and forcing patients to go into the appeal process. And so what I would say is, if the doctor is, if the physician is making the prescription and is making the case when submitting the information and they meet the criteria, that should not be an automatic denial that provides a barrier for that patient to get access to the medication. Would in no way want to circumvent the physician in the same way when we talk about step therapy.
I was gonna mention it.
I don't want to get, sideways with that patient and physician relationship. I think they know better than the insurance company.
But are you saying, Shannon, that there are people that we cover that have a doctor who is prescribing this medication and they're being rejected by our plan?
It can happen.
So I would say that anecdotally, that has happened to me.
Okay, see, I would like to change our rules so that if a doctor prescribes it, that we accept it. Why would we reject it in those cases?
See, and that gets into the cosmetic feeling. If someone wants to lose 4 pounds, you can find a doctor that will write the script with
Yes,
a call in.
then when you go through the appeal process, which then the doctor has to go through and fill out all this paperwork, when it's pretty clear that there was nothing out of the parameters for it. If you meet those, that's what the requirement is. So I would just say, I suspect that it happens on occasion. It happened to me. It happens on occasion. I'm not saying that our provider, because we hire somebody to manage this for us, that is their internal policy. I'm just saying perhaps we want to make sure that if they meet the medical conditions for it and their physician, is prescribing it, then they meet the medical conditions for it.
Well, okay, so if I have to vote on this, and I'm not saying that I do have a vote, I want
You
to
do
help
have a
them.
vote.
Well, I want to help I want to help those people because based upon the research that I've read, this is helpful. I mean, a lot of what the FDA does is take and weigh, costs and benefits. But when it comes to this, I believe the health benefits are tremendous. And they're clearly from people who are on it, and Shannon has personal experience with this. I don't, but I mean, clearly she can testify that it's been very helpful, and I think that that's broadly the case now. And that is what the evidence shows, and what we're reading about, and why this has been expanded. And in terms of the danger of this drug, well, I mean, these drugs have been used for decades with diabetes. They got a long history of study of this, and they're not dangerous. But so my vote would be to make this less restrictive.
Well, do you want staff to work with HUB to come
I
back
would like
with
that
like
staff,
a?
and maybe Shannon is your key person that has to be, a big
Yeah,
understanding of what this done.
I just wanna be clear on what I'm saying here is, yeah, I mean, since I brought this up, this is where I'm trying to get to the real effects.
Yeah.
But now we're getting into, if a doctor prescribes this for you, you get it. Your primary doctor might have said, absolutely not. You're 4 pounds overweight. You don't need this, and it's $1,000 a month. No
Yeah.
way. But you can call an 800 number,
Yeah,
spend
I-
15 seconds with a doctor that's never seen you. You fill out the questionnaire, and they will give you a prescription. That is what happens.
Yeah. But
And so
that-
now you have an actual prescription.
But that
for this.
prescription in our plan wouldn't be covered by our plan because they don't meet the 4 pounds doesn't meet the medical indication for that particular drug.
Okay, so that's where I was going with what are the other, that do we make this incrementally less restrictive? That, okay, so, because you said something about, well, it's BMI and then there's these other conditions hoops you have to jump through to get it. Well, if our employees really need it, I don't want to see them being denied and that the first go-to is denial. That, could we make it, not everybody that has a prescription gets it, because again, I know the way this game works, but it's also, can we tweak the plan to have people that are actually in need have a better experience of getting this in a timely manner? So,
Martin asked
Yeah.
the question. I'd love it if the staff, in conjunction with Shannon and with these people, come up with some sensible way to make this more accessible, less restrictive, but also acknowledge the fact that we are not trying to lose 3 pounds here.
That's right.
I honestly would like to lose 3 pounds,
Yeah.
okay? But I'm never really, outside, I'm not, in terms of
Yeah.
BMI, I'm pretty low. But
And you're not vain.
no. Of all the people at this table, okay.
Yeah, I mean,
But anyway,
I think that's fair. I mean, I don't, and in fairness, in the 2 years that I have had experience, this has come a long way too. So we have learned, the field is learning, the insurance companies are learning, the manufacturers are learning. So we're coming a long way to ensuring that the right people are getting access to these, medications. And, I've lost 110 pounds. That is not something that for 40 years of my life I was ever able to do. And, it's been life-changing for me. And so to the extent that we have, covered lives that could benefit in the way I have, but I, was paying for it myself for a long time, and my deductible got maxed out first, and so there's real costs associated to it that is a barrier to a lot of people. And so, I want to be transparent to say, Tammy and her team have done a lot to really streamline it and curb the acceleration and costs. So it's like both things. We need to do both things at the same time to the best of our abilities. And I think it's right to ask, for us to continue to work on that for a whole variety of drugs. But most of these, a lot of these up here, of course, aren't weight loss drugs.
yeah, and again, number one, good for you, and thank you for sharing. I think that's important. You obviously, you chose to share, and that's great, and we've done that individually on other matters about this, but I think that's, praise the Lord, that's great, because there is a correlation with people's health, which I go back to my original points. We want healthy employees, and we want to save money.
Yeah, exactly.
That's my goal,
Yeah.
and period, from our standpoint.
Yeah, I agree with you.
And so now and I think there is, and again, for the taxpayers, they're paying for weight loss. There's a correlation, and that's where I'm kind of bringing it back into the taxpayers of why are we doing this? Our plans cost went up 2.5%, the national trend 7%, right?
Yeah.
Okay, so now I'm trying to get into the weeds
Yeah.
of, can we really go from, and there is quantitative data, I am sure, that people with highest BMIs, what is the correlation with their spend on the part of our plan? Can
Right.
we reduce the people with the highest BMI?
Yeah.
That's where I'm going with this.
Yeah.
And
Yep.
again, I think that is a worthy goal, and as my colleague said, I would say try to work with staff of, there's clearly a direction from the board of, we believe in these products, and I believe in the results for, again, not cosmetic reasons, a few pounds here or there, which put me at the top of the list, but the correlation for people that are really have underlying health conditions.
Yep.
And I would say staff is actually very excited to have this, that you had this conversation, because these are conversations that we've had with Hub internally about trying to get your direction on what in the a grander marketplace is a sensitive conversation. So this is actually very good
But
for
again,
us.
I will, that's why I brought it up when I saw the word, that this is not a sensitive conversation to me, because I'm about healthy employees and saving money.
Yeah.
And both of those, I think, this is why I'm trying to get facts, it's not feelings, facts of the highest BMI folks on our plan. If their BMI has come down, has there been a correlated drop in
Right.
health insurance costs? You're our health insurance experts, my guess I know the answer to that question. What is the answer to that question?
I think once we have more of that long-term data, we'll have an answer.
But in the short term, we have seen a dramatic reduction in trend, correct?
Right.
For this plan year. And I remember specifically talking about this issue because, there's prior folks on prior board, absolutely, we're not paying for this stuff. That's a cosmetic thing and we're
Yeah.
not gonna do it.
Yeah.
And
Yes.
that was a change for this board, like we've changed a lot of
Until I have a
things.
stroke or a heart attack,
Yeah.
and now I'm in the hospital and having open heart
A
surgery.
$100 to $500,000 claim.
And it's hard to, put a value on things that don't happen. So it's like, I am now much less likely to have a stroke
Yeah.
or a heart attack, or, require long-term diabetes management or whatever. But that's not, it's like, how do you quantify there's not a date on which that would happen, but it's like the statistics are not I mean, that's the hard thing about prevention, is all the money that Tammy is,
Wellness
has been
programs.
working on for
Yeah.
prevention. It's hard to say, like, okay, we're investing this money, what's the ROI on it?
Yeah.
Even though we know it's there over a 20, 30-year period of time,
Yeah.
it's very hard for you all to quantify, and I get that too.
But I think just when you implemented the preventative maintenance list, to see the amount of scripts the next year that went up, otherwise people who were not taking medications that were taking medications, it's going to, again, anecdotally, it's going to have results. And that was a decision you made 3 years ago, I think it was, and we're seeing some of that.
Yeah, and again, all this stuff, but it is important since people are like, well, why are they paying? We do a day for your life. We've done all these things ahead of time, and even though we say we're guessing, we're not guessing, because our numbers of our plan don't lie. Average is 7% up. There's lots of plans, I'm sure other counties, what have you, 10, 12, and these are big numbers. This is millions of dollars
Yeah.
to the budget.
Yeah.
Ours went up 2.5% year over year. I say there is a direct correlation between, I just didn't want to say it, I wanted you to say it.
Next year.
Next year, I got my notes. Yes.
So all the things that we're doing, that we're spending a little bit of money on here, there, half day off from work to go do this, to encourage people to do it, I say all that stuff is working, and these numbers are showing it.
Well, I think you'll see in the next slide with the Samaritan Fund, even more things that we've spent on that has brought savings down, and not to steal our thunder.
Fair enough, yeah,
You're
I'm
good,
sorry
you're good.
I took us
No,
down that.
I appreciate it. It's a good conversation. So to Martin's point, going into some of the other options out there that you all implemented, just being, due diligence of ensuring that you're doing the right things from a cost containment standpoint, keeping your employees healthy, to your point, and managing cost. This program you implemented in 2025, and we recommend moving forward into 2026. Essentially, what this is, the Samaritan Funds, it provides other alternative coverages to members who are experiencing, ongoing catastrophic severe diagnoses where their coverage, so their deductible out-of-pocket expenses and their premium are paid for at 100% by donors throughout the country. We have a handful of clients that utilize this program, and they all speak highly of the program. I know that Tammy and her team have received testimonials from employees who have benefited from the program, basically saying that it's taken a huge weight off their shoulders. They don't have to pay for their expenses anymore, and there were only a few expenses that were not covered 100%. So great program. People who have taken advantage of it in 2025, everybody who's still benefit eligible will be taking advantage of it and have been approved into 2026. And I know that there's been communications that have been distributed for moving forward into 2026 as well.
I read the testimonials from the plan members, and I was really happy that because the other side of the equation is the out-of-pocket expenses that our members, and we were talking about a very small percentage of families that can take advantage of this,
Right.
but they have been able to save their families, really devastating medical costs. And in fact, I think one of the testimonials mentioned that because of this program, they're now able to start paying down their medical debt that they have continued to get increase year over year.
Yeah.
And so that's, certainly there is a plan savings, but with these families in particular, huge out-of-pocket savings to them, which made me feel really good that they were able to get that kind of assistance.
I agree. All right. So that will continue. One other item we wanted to bring to your attention is regarding to eligibility on the plan. Something called trailing spouse is what we are recommending moving forward in 2026. Essentially what we've been seeing are people on family plans, if for some reason the employee becomes Medicare eligible, they turn 65 and they're Medicare eligible, however their spouse is not 65, they want to remain on group health plans because they want to ensure that their spouse still has coverage until they are Medicare eligible. So we're seeing an ongoing trend of offering what's called trailing spouse, essentially allowing that spouse to remain on the group health plan until they turn 65, and same thing for dependents. If they have dependents on the plan who are still under the age of 26, they can also stay on the group health plan until they turn 26. So recommending this, the goal and the reason, from a cost containment standpoint, ensuring that those 65 plus individuals are able to go onto Medicare. We have a whole individual Medicare team at Hub that helps walk them through the process. Typically, they're higher risk, from a cost perspective. So managing that and making sure they feel comfortable moving on to Medicare, that's our team's job. And then ensuring that that spouse and dependent still have coverage. Any questions on that?
So,
Why wouldn't we do? I'm sorry.
yeah, I kind of don't understand that. So employee retires, 65, goes on Medicaid, they've got a 60-year-old spouse. We're saying,
So they cannot retire yet, so they're still working at the county and technically eligible for county benefits. They become Medicare eligible. So many times what happens is
They
if the
choose
spouse
to
is
stay on our plan because
Exactly.
of concern for their spouse, as opposed to going on Medicare because
Correct.
then their spouse isn't taken care of. So they're still employed. So you're basically suggesting we remove the disincentive for an employee to choose to go on Medicare if they want to at age 65, and it won't hurt their
Correct.
family members if they're still eligible.
correct. Yes.
If I could speak, go ahead, Dave.
I was gonna say, and as long as they're still employed.
Yes,
Right.
yes, yes.
Correct.
And if those employees choose to stay on the plan and also on Medicare, we're always gonna be primary coverage to Medicare. So that's another good reason to, as far as data goes, we have, age 65 or over, so Medicare eligible. We have 72 members. 38 are employees and 34 are spouses. So in the situation about the trailing spouse, it would, for those 38 employees that might move off, their spouses could stay on. So it's, but that's what the numbers look like. We have a total of 72 Medicare eligible members.
Okay, thank you.
The one caveat with this, stop loss, I know everybody's favorite conversation. You all being self-funded, you are the plan sponsor, the fiduciary, you create the rules of your plan, right? The one thing is we would just need to get acceptance from the stop loss vendor to ensure that this eligibility language is approved, which we were waiting for your stop loss renewal, so I didn't want to negotiate that without the renewal, so when we
But I
come to
can't
talk to
imagine
stop.
that they would look at this as a
No.
disadvantage.
I
They
think
would
we
see
should be
this as
fine.
an advantage to them on the
Yes.
insurer side.
Yes. The only, devil's advocate there is if the spouse has an ongoing diagnosis, right? And so if they're remaining on the plan, it still remains risk and cost for the county and ultimately the stop loss carrier. If
They
it is.
would remain on the plan if the employee
Correct.
doesn't, so
Correct.
that's a distinction without
Yeah.
a difference.
Mhm. Yep. So I foresee no issues with it, but just that caveat. Alrighty, I think that this is still, is this the 15? Do we want to show,
Yeah.
is that okay? So we had a couple different contribution sharing options to show you. This presentation right here is showing consideration of a 15% increase to the fully insured equivalent rates. We have this option, and then I don't know if the printed one is 10% either, but we're going to show you two different options here. 2.5 to the 15%. The goal here is to just from ongoing, the last 2 years were higher than typical costs, right? We had large claimants on the plan, the pharmacy spend. So to get our fully insured equivalent or funding rates to, I don't want to say a reset year, but essentially a reset year to get to where we want to be, we do recommend an increase to those contributions to get those in line. This scenario here is showing if you kept the 15% cost share to the buy-up plan and then keeping that base plan at 0%.
Where are we now?
For the contribution,
Yeah.
it's the same, the 15% for buy-up and then 0%. So base plan, nobody pays for that plan.
And what is the industry standard?
So I would say for public sector, we see it's much more lenient with employees, obviously, of the cost share. I will tell you, on our book of business, we do not, and me personally, I do not have any clients that have a plan that covers it entirely for free anymore. When we look at county plans in the state of Ohio, I believe you all are pretty much the only ones left that cover a plan entirely for free.
And so then what is on average of counties in Ohio? What is there?
Typically, I would say in that 15 to 20% cost share for the employees.
So even at our buy-up plan, it's at the low
Correct.
end at
Correct.
15%.
Mhm. And we have from that and best practice too, you are 15% across the board. We see employers, public sector, municipalities change those, fluctuate them, so the employee only rate is not 15%, maybe that's 10%, and some of the other ones are more than the 15%.
So our entire family plan, if you're kind of on our buy-up plan where you're actually paying a monthly premium, the employee for an entire family is $356.
So that is proposed for 2026. On the left-hand side, you see current.
Oh, yeah.
There's a lot of numbers on here. So
Yeah, that's right.
the 310, the one that's not circled. So if you go to the employee rates, right here for a second.
Yeah, the 310.
Yep, those are the current premiums.
Yeah,
on a monthly
which,
basis.
again, it's not just county government, but literally private sector. I mean, what are you paying out of pocket for a family plan now out in the real world? $1,200, $1,500 a month, $2,000 a month?
Right,
I
right.
mean, really?
Yeah, it varies obviously depending on the industry, right? But yes, I would say your numbers here are much lower than what we typically see.
Which is a kind of an employer question for us, that this is great, but yet we still have problems with attracting people don't see it, but yet we're still.
Yeah, because it shows up in the deductible, right? Like it, and so that's what
Yep.
people are focused on is, I gotta pay this deductible. And so they're not focused on, what they're not paying in payroll deduct.
Right, right. Mm-hmm.
Because there's no baseline of,
Right.
they just always worked here, and wait, it used to be nothing, now it's a couple, now it's $300. But again, I hate to say the real world, but the real world, I mean, a family plan will cost the employee out of pocket an easy $1,000 a month, if not $2,000 a month. I'm right?
Yeah, yep, you're right. Correct. Yeah.
Because on the base plan then, it's showing, by keeping that at 0, the monthly for a family, would be $2,094.69. I'm looking at HSA base,
Mhm.
and your EE rate, we're in the block to the left of that, where it says renewal total rate.
There's actually two, and when I copied this was the last one we did, there's a 15% and there was a 10%, because Tammy was working the numbers, but on the 10%, the number that you would see would be 2,189.
That's a month, that's what the plan pays, that's the plan cost monthly.
Correct.
So if I just wanna make sure I'm understanding, so if there is a, covered life here, a family, employee with their family, and they choose the base plan, that cost to the county is roughly $2,100 a month that we assume. And so that is roughly $25,000 a year that the county is paying for that family to have insurance, for which they are paying $3,500 or $7,000. Is that what
Yes, correct.
the most that they would pay is $7,000 in their deductible?
Deductible. Mhm.
So
Yeah, 'cause
that's a
theoretically-
pretty good deal.
Oh, yeah, right, well, right, so because then, in theory, if they don't utilize the plan, even though we're charging that, it doesn't really cost the plan $2,100, right? 'Cause
Correct.
there's
Yes,
no
in theory,
utilization.
yes, it's more of a
And-
budget number.
And then
correct.
the employee is on the hook for the first $7,000,
The
right?
family.
For the family.
Mm-hmm.
So that's where, which is then, what, $700 or $800 a month, which is okay, because then that's kind of the risk the employee's taking.
Yeah.
That's a fairly good deal for us too, isn't it?
Yeah,
I
think so.
I like that plan.
Yeah, I think so.
That, people that are low utilizers can basically bet on themselves.
Correct.
Doesn't cost them anything out of pocket. We, as the insurance company, doesn't cost us anything. We're just it's a budgetary number, but it doesn't really cost us that, because we only really start writing checks until 100% of that deductible is actually met by the employee with a family.
Well, we pay for the primary care visit, so
Oh, yeah, there's,
There's some small incidentals,
Yeah,
but the
so
bulk comes out.
mammogram, OB-GYN, annual exam,
the preventative stuff.
preventative
basically.
stuff, so we pay that.
Office
But when you
visits.
think about what's driving your spend, it's, typically we're seeing 10% of your population drives about, 90
Yeah.
or more of your spend, right? So to your point, yeah, most of the people on your plan, the utilizers, are the low utilizers that might not even hit that deductible, don't hit their out of pocket. So yes, they're winning in that game. But then when you have a couple of the high spenders, obviously that's where the drive of the spend
But
is
are
coming
we
from.
winning in that? If the employees are winning, low utilizers, are we as the plan winning also by offering this zero out of pocket to the
Yeah,
employees.
so that's why the recommendation would be to increase that, because the last 2 years, from where we know from, for example, your stop loss ratio of what has been paid out in reimbursements due to a couple high cost claimants has been much higher than it has been in years past, right? And so the last 2 years, I would say, no, there has been a loss from that. We are seeing that reset, right, of, you know, managing that spend, not as many frequent large claimants we're seeing on the plan. So hopeful into 2026, we'll get to that winning place again.
Well, why would we make a change based upon something that's not gonna occur in the future? Or that you don't think is gonna occur in the future?
Just from a reset due to the loss of the last 2 years.
But then the other thing is, are you saying that what you wanna do is increase these percentages to have people that are not costing us any money, basically spread the cost to them for these few high payers? That's what you're doing.
That is part of, yes, it's a tough conversation of trying to figure out where that money's coming from, right? From a plan design change, increasing deductibles out of pockets, or embedding those into contributions, right? So you're not alone. That is a conversation that's tough to have, of trying to understand if somebody's not utilizing the plan, it's not something that you want to have to increase premium for them. However, what we're seeing from inflation and medical trend, it's higher than we've ever seen it before.
But again, on the base plan, that doesn't really affect the employee.
100%. Yep.
That's just our internal allocation of trying to
Yes.
set aside money, right?
Yes, correct. So to that point, yes, if you're in the base plan, if it's going up in the buy-up, it doesn't really affect them because they are not paying anything on the base plan. The one thing to think about, as the buy-up plan incrementally will increase year over year. So what we have seen is a slow migration of those on the buy-up moving to the base, because they're like, why am I going to pay for premium when it's going up and I don't have to pay on the base?
Yeah, as long as you have, and again, a lot of our employees are in a position, praise the Lord, that they can afford to write $1,000 checks for deductibles and things like that. That is a better deal for them. But if they're not in that position where I don't have $2,000 saved if somebody goes in the hospital or what have you, I have to have that insurance from,
Right.
you know, almost $1. I mean, there's a small, with the buy-up plan, what's the deductible amounts?
The buy-up is the
2,000 single
Something out,
and
okay.
4,000 family.
and the out-of-pocket too, if you think
It's
about,
double, it's 4,000, 8,000.
because that's the maximum
So
exposure.
we
somebody can
probably
pay.
need to, this time next year, be looking at that migration from the buy-up plan to the, zero pay plan, because that might change the calculus over time.
Right.
Which is
right.
what you're foreshadowing, you're
Correct.
saying it's going to do that, so you
Yes.
should consider something more
Correct.
aggressive.
We do have another illustration that is showing some of the cost share on the base plan, but keeping the employee only zero. We're seeing that more across our book of business of enticing those singles on the plan, of still keeping a free plan for employee only, but then adding some sort of cost share for those that cover spouses or dependents.
Allison, I think I have some numbers that kind of back up what you're saying, how they're migrating. Is, we currently have 1,048 employees eligible for the plan, and 149 of those have waived, so a total of 899 employees on the plan. And the base buy-up, the base is 500 employees, and the buy-up is 399 employees. So it's, there is definitely a shift over to the base plan. 56%, 44% would be the percentage.
Do we want to go into anything else about the 15 or 10, or do you feel good about that? Okay. Okay.
Tammy, what do you think?
I think that we need, I'm right with Allison on the, so we said the plan, we had a really bad plan last year. So I think to get those, to increase those rates, we're not, we're no longer with Optum. So we're not receiving the large Optum discounts that once were used to kind of work with the rates to to fund the plan. So I think it is needed for a reset of the plan to get the revenue and balance.
Well, how would this, what is the total dollar impact if we don't do that on us? What's the projected impact on us? And what's the projected impact if we do follow a increased recommendation on our individual, insureds?
Yeah, this is showing the total cost summary, but this is the fully insured equivalent projected increase is different. This is where we have a different, from a budget perspective, there's more in the all-in budget for that 2.5% increase that Tammy referred to earlier. The fully insured equivalents here, you can see at the bottom here, this is basically telling you, how you currently are set up from a cost share standpoint. If you took the 15% and kept it the same contribution share, what that total increase would be for the county compared to the employees.
See, you're gonna have to, all this, when you say the bottom, I'm looking at, I'm swimming in these numbers.
Yes.
There's a microphone over there, you can talk with him.
Oh, okay, perfect. So if looking at this, at the bottom here, the total cost summary, this is showing today, currently, based off your fully insured equivalents and what you're charging the different departments, the total revenue coming in and the total that the employee is paying. So you can see the 11.8 for county cost and then the 891,000 annually for the employees.
So about 12.6 million.
Correct. Yes.
And we've been around 12 million plan costs for a while, I thought.
Yeah, I have to check my notes here on where you are year to date for 2025, but yes, to Tammy's point, there's other things that go into the budget cost, including rebates through Optum that she used to offset some of these contributions. I know it gets a little convoluted.
But it strikes me that those rebates from Optum aren't here anymore, but it also might be contributing factor to why we have people moving from the buy-up to the base plan, because now that we have these drugs, for example, a greater complement of preventative drugs that they're able to access at no cost. So
Exactly.
so that would strike me as a need to, because it's not necessarily, oh, well, these are all the healthy people and healthy families,
Yep.
and then the buy-up was the unhealthy. It's really, our benefits structure has also, our benefits have also increased.
Yep.
And that's perhaps contributing to employees making different decisions about which plan.
Yes.
There's an increased deductible.
Yep.
But they're making that financial determination.
Yeah.
Okay, so
Can't do anything on the deductible side. I'm sorry, Tom.
No, that's okay. All right, I'm still confused. So what is what are you projecting our cost will be if we make no change? And what is the cost to our employees if we do make a change?
Tammy, do you have your budget numbers?
So if we, as far as rates go,
Yeah.
Yeah, if you're talking
I
just
want to know our cost, total cost, if we don't make a change, and what our employee cost is if we do make a change.
so I hope I'm answering the question the right way.
Well, the employee cost goes up 130 grand, right? That's what,
Well, yeah, that's a total. I want to know what the individual cost is.
So to employees now.
that's up above.
Okay, tell me where the up above. I don't.
right here. So individual costs, so for employees,
Yep.
if you're looking at, for the base plan right here, so if the rates ended up going up 15%, this employee rate dollar amount would be on a monthly basis how much more those would increase monthly. So
Okay,
if you're employee only, those rates are going up $15.51 a month.
Okay, and so those are the total costs if we increase by what percent?
15.
15%. Okay, so then what is our savings? What are our increased costs? So we're gonna save what by doing that?
So if you go to the total cost summary, basically what's going to happen is $133,000 will be remitted from the employees. So essentially that's coming from the employees rather than the county. So that would be,
It's confusing you because, oh, you're looking on there, okay, good.
Well, it's going, again, this is just for budgeting purposes though, but the employee money, that really is going into the kitty.
It
So
is.
that's going in to the health insurance pool.
Fine.
Our money is, we're just budgeting for that because we don't know what it really is.
Yeah, but so the real employee cost of what we're talking about is $15 for a single, almost $35 for an employee and plus spouse, $27 for an employee that has a child or a couple of children or 3 children, but no spouse, I take it. And then the family, which is including spouse and children, which is $46 a month, or about $46.50. That's right?
correct.
All right, and so, and for that, we're saving us, the county is getting in another $133,650, right?
Yes.
Correct.
All right, I mean, from my standpoint, I'm not really jazzed either way on this, but and I don't even know what that word means really, but
Well, and it looks like the premium share here is an employee is paying 7% and the plan is paying 93%. Maybe that's a better way to look at it is,
Yes.
are we okay with employees paying for 7% of their health insurance? And we pay 93% of it? Or do we think that number should be higher than that? I mean, that's,
That's a great way of phrasing it, and it's
Yes.
also, that is just so, I think your first statement, that's just so not the real world, right? I mean, it's not, Steve, you've been with us forever, I mean, this is just, I mean, it's almost getting worse on our share versus employee share.
Yeah, it's phenomenal compared to the markets at 93.7 overall, when you're looking at both plans. I mean, you guys definitely.
I'd
combine.
love to see an 88 county breakdown. Does something like that exist?
Yeah, I have that information. I have all 88 county, 82 participate in the SERB survey.
Yeah,
So
yeah.
82 counties participate in that, and so, that report can be whittled down to, okay, of all the counties, you can look at it regional, you could look at it by only counties with high deductible plans like ours. And it's really, it's interesting, the facts that come out of that, and I'd be happy to share that.
I'd love to see
And again, from an employer standpoint, again, we're in a public meeting, and the older I get, the more transparent I am, I think, that we have lost the battle to some degree with employees and even new employees relative to, used to be when you came to work for government, Tammy, what was it? Job security and benefits. And that's why you did it. You're not gonna get laid off unless something crazy happens. And, you get really good benefits. PERS plan, you're gonna have all this money, you get 13% of your salary put away, and people would take less money on a wage basis to come and work for government because of job security and benefits. That's not the world anymore. The market, the employees are saying, but I can go get 50 cents more an hour over here. And we tell them, but your retirement's no good, and you look at your benefits, and the employees say, I don't care. I need the extra 50 cents an hour. So if that's what the market's telling us from an employee standpoint, I think we do need to slowly change the plan, which is exactly what we're doing, to make it more conducive, because we can't keep doing everything. We can't keep having the best retirement plan in the market, which is the Ohio Public Employees Program. It just is. We can't keep doing that and having them only pay 7% of all healthcare costs and pay them market wages like they were going to a private employer. That's not a good recipe as an employer. So I agree with the fact we should be tweaking the employee share up.
Well, I would say looking at, not to keep the judges, is I think I would recommend that Allison come back in the very near future for us to finish this up.
we've got a ribbon cutting.
And a ribbon cutting at 10:30, so Allison, can we work with your schedule to
Do we
get?
have time? I mean, is there something that you need us to determine today that can't?
Can we do pre-tax benefits really quick, or?
Yeah, and the dental, the change to the dental.
Yeah, is that
Delta
okay?
Dental, I read that, you're
Yes.
suggesting.
Yeah, we can come back and do the medical. I think the two things, one of them is the pre-tax benefits administration. There's been some conversations of just evaluating the health savings account. With that comes your other pre-tax benefits administration, so FSA, HRA. We looked at a TPA to streamline that all together. So something to consider is streamlining those with one vendor. Flores is a company we work with on a national basis. The sales leader actually is here in Lebanon, Ohio, actually. So worked with him on providing a proposal to streamline those. Essentially, the FSA, HRA costs that you pay today would remain pretty much as is. The only additional cost would be is if you move the HSA. Right now, with First National, there's no essentially cost. What we're seeing in the market are banks are kind of going away from the HSA business. They don't receive a profit. It's not a big part of their business. So working with TPAs that manage HSAs, you have a point of contact. We've been seeing a greater trend to move towards that.
So you're saying a total fee to move away from that, which I have not been a big fan of the way it's administered now.
Yep,
Per participant per month, but the aggregate total, that's like 18 grand.
correct.
Yeah.
Annually, the change.
To go from an antiquated
National
system that you don't know how much is in there to
Correct.
pull it up online, you see where everything is, and it's very transparent.
Yes, they have a portal, dedicated point of contact.
I think actually the card that you'll have now actually will reject certain purchases, so.
Correct. They have it's called a Benny debit card. So through an IIAS system, it knows what is technically a eligible purchase, if you will, for HSA, FSA administration. So you would get a new card.
All right.
I think
Yeah,
I'll give this
we're
some-
good?
I'll give it-
Okay. All right, we will get into dental really quick and then we can come back. Dental, I think you all are familiar. We've done an RFP just to evaluate the market due to some Sun Life woes and issues as we see their network kind of disintegrate a little bit. Recommendation is to move to Delta Dental. What we see with Delta is they have the largest network nationally. When we look specifically for the county employees, you can see it there in the charts. Higher percentage of in-network currently used dentists today. So good news there. We do project, you are self-funded, so we do a projection based off prior utilization data of what we project your dental costs to be in the future. We're projecting about a 1% increase. However, this does not take into account Delta Dental's discounts. Delta Dental does have greater discounts than Sun Life, so essentially we could even see a cost savings moving to Delta Dental from Sun Life.
Makes sense.
Okay. Yeah, I'm okay with that too.
Good deal.
All right, we'll get on your calendar and get you back up here quickly.
Perfect, thank you.
Thanks very much.
Appreciate the time.
Appreciate it.
Do we need a motion to adjourn this meeting?
Yes, so moved.
And, we don't have a budget?
We're not gonna be,
Well-
not today.
Oh.
We got the ribbon
We got
cutting.
ribbon cutting at the county courthouse.
So we'll
10:30.
we'll figure out, we'll get it back on the next week, we'll figure it out.
Right.
All right, thank you.
And we got okay, all adjourned. Thank you. You need umbrellas to go over there?
I haven't looked.
Right.
Yes, I guess we can.
Yeah, you got it.